Have you ever wondered what truly orchestrates the incredible symphony of processes inside your body? From making you grow, to managing your energy, or even influencing your mood and behavior, there's a hidden network of tiny but mighty chemical messengers pulling the strings. It's dense, it's complex, but here's where it gets really interesting. Welcome to the Deep Dive, where today we're peeling back the layers on one of the most fascinating and fundamental systems in human biology, the endocrine system, and specifically its master control center, the hypothalamic-Pituitary-Endocrine axis. We've gone deep into a foundational expert source, GOODMAN and GILMAN's The Pharmacological Basis of Therapeutics, to bring you the essential insights. Our mission in this deep dive is to give you a shortcut to being genuinely well-informed. We're transforming dense academic material into clear, digestible, aha moments. Our goal is for you to gain a foundational mastery of this topic, understanding not just what hormones do, but how they work, why they matter, and what happens when things go wrong. We want you to grasp the core concepts with the clarity and understanding of elite professionals in this field without getting, totally overwhelmed by every single detail.
Indeed, this system is a prime example of the body's intricate design and profound interconnectedness. My role is to help you connect these seemingly disparate pieces of information, spotting the underlying patterns and understanding the broader implications of these powerful chemical signals. We'll explore the nuance, question assumptions, and ensure you grasp the core concepts thoroughly, making complex ideas truly click into place.
So if you're ready to master how your body's most powerful chemical messengers truly operate, let's unpack this.
The chemical messengers, hormones, and endocrinology fundamentals.
Let's start at the very beginning. What exactly is a hormone? The term itself is of Greek origin, meaning to set in motion or to excite. Classically, a hormone was defined quite simply. It was a chemical messenger that circulated in body fluids, like the bloodstream, and produced specific effects on cells located distant from where the hormone originated. You can think of them as tiny, highly specialized postal workers delivering very specific messages far from their point of origin to precisely influence cellular behavior.
That's the classical view, which initially focused on hormones as products only of what we called ductless glands, traditional endocrine glands like the thyroid, adrenal glands, or the pituitary. However, our modern understanding of endocrinology has vastly expanded. We now appreciate that many tissues and cell types not traditionally considered endocrine also synthesize and secrete hormones that play key physiological roles.
That's a crucial shift in perspective. It's not just the big named glands anymore. Think about surprising players like the heart, kidneys, even parts of your gastrointestinal tract, fat cells or adipocytes, stem cells, and even neurons. All of these produce and secrete hormones. This emphasizes that our current understanding focuses more on the cellular origin and action of hormones, rather than just requiring them to come from a traditional gland.
And this broader scope means endocrinology now includes substances that act through what we call autocrine and paracrine mechanisms. Autocrine is like a self-memo. A cell releases a hormone that then acts back on the very same cell that secreted it. Paracrine is a local whispered conversation. A hormone acts on nearby cells without ever having to enter the general circulation. It's a localized, highly specific communication.
So it's not just a body-wide broadcast, but also these highly localized, incredibly specific communications. And let's not forget the profound influence of neurons, especially those in the hypothalamus, a part of the brain, that regulate endocrine function through synaptic action or by secreting peptide hormones.
Exactly. And it truly highlights that your body isn't a collection of isolated systems, but rather a constantly communicating, intricately interconnected network. Every system is talking to every other system all the time through these amazing chemical signals.
So these tiny messengers are basically the central command for some of the most fundamental processes keeping us alive and thriving. Our sources detail 4 major functions that these hormones are responsible for.
First, they're the chief financial officers of your body's energy economy, the regulation of energy storage, production, and utilization. This includes everything from managing your blood sugar levels to deciding when your body burns fat versus stores it.
Secondly, they play a critical role in your body's adaptation to new environments or conditions of stress. Whether you're facing a sudden physical threat, adjusting to extreme temperatures, or dealing with psychological pressure, hormones prepare your body for immediate and long-term responses. Think about the fight-or-flight response. That's hormone-driven.
Third, hormones are essential for the facilitation of growth and development. From the rapid growth spurts of childhood to the precise maturation of organs and tissues, hormones are the architects guiding your body's construction plan.
And finally, their fourth major function is the maturation and function of the reproductive system. The entire intricate dance of fertility, pregnancy, and sexual development is entirely orchestrated by these chemical messengers. So these seemingly tiny molecules are fundamentally running the show for some of the most basic yet profound processes, keeping us alive, adapting, and thriving every single day.
No. To go deeper into how hormones operate, we conceptually divide them into two major classes based on their mechanism of action. This distinction is about how they deliver their message at a cellular level, much like different keys fit different locks. The first class are the nuclear receptor modulators. These hormones are usually small and fat-soluble, allowing them to diffuse directly into target cells. Once inside, they bind to specific nuclear receptors located either in the cytoplasm or directly within the nucleus. This hormone receptor complex then literally interacts with the cell's DNA, directly modulating gene transcription.
Okay, so they're changing which genes are expressed.
Precisely. This means they influence which genes are turned on or turned off, thereby affecting the long-term production of specific proteins.
So these are the long-term planners, right? They're changing the fundamental blueprint of the cell.
Exactly. Examples in this class are the steroid hormones like cortisol, estrogen, and testosterone, as well as retinoids derived from vitamin A, thyroid hormone, and vitamin D. Their effects tend to be slower to manifest but are typically sustained and long-lasting, leading to fundamental changes in cell behavior. They're like profound, long-term policy changes in the cell's government, directly influencing its fundamental identity and function.
That makes perfect sense. So what's the second class, the rapid responders?
The second class consists of membrane receptor activators. These are typically larger or water-soluble hormones, which means they can't easily cross the cell membrane directly. Instead, they act by binding to membrane receptors located on the cell's outer surface. This binding then triggers rapid effects on intracellular signal transduction pathways. These pathways often involve cascades of protein activation or the rapid production of second messengers like cyclic AMP, often called CAMP or calcium.
So these are like quick, immediate signals rather than long-term blueprint changes.
Exactly. Examples here include peptide hormones like insulin and growth hormone, and amino acid hormones like adrenaline. They're more like flicking a light switch or sending a quick text message to an established system, triggering an immediate cascade of events already in motion within the cell, leading to very quick dynamic responses. Their effects are rapid and often involve modulating existing cellular machinery to make swift adjustments to cellular activity.
That's a great distinction. Fundamental, long-term changes versus rapid, immediate responses. But there's a fascinating exception mentioned in the source material for this classification, isn't there, with the steroids?
Absolutely. It's important to note that steroid hormones, which we typically categorize as nuclear receptor modulators, can actually operate through both nuclear and some membrane receptor mechanisms. Their specific effect on an individual cell is ultimately determined by the unique receptor complement present in that cell. This highlights the incredible specificity and adaptability of hormonal signaling, showing how a single hormone can elicit different responses depending on the cellular context.
And from a pharmacological perspective, this understanding is incredibly powerful, isn't it, for developing drugs?
Indeed. The receptors for both classes of hormones provide what we call tractable targets for a diverse group of compounds. This means they are highly accessible points of intervention for drug development. Drugs that target these natural pathways are among the most widely used in clinical medicine, leveraging these precise mechanisms for therapeutic intervention. This is precisely why understanding these basic mechanisms is so vital for you to grasp in depth.
The master control system, Hypothalamic-Pituitary-Endocrine axis.
Now that we know what hormones are and broadly how they work, let's zoom in on the command center that ensures this whole system runs smoothly. It's a complex, beautifully orchestrated feedback loop known as the Hypothalamic-Pituitary-Endocrine axis. Think of it as the ultimate central command center for your entire hormonal system.
Precisely. The core components of this axis are the hypothalamus, a region deep within your brain, the pituitary gland, a small gland nestled at the base of your brain, and then various target organs or tissues throughout the body, like the thyroid, adrenal glands, or gonads. These three components engage in complex reciprocal interactions, constantly influencing each other. Imagine a chain of command where the hypothalamus sits at the top, sending signals down to the pituitary, which then signals to the rest of the body.
And it all starts with the hypothalamus. What's its specific role in this intricate dance?
The journey often begins in the hypothalamus, where Discrete sets of specialized neurons produce different releasing hormones or inhibiting hormones. These are the very first signals in many endocrine cascades. For example, you have corticotropin-releasing hormone, growth hormone-releasing hormone, gonadotropin-releasing hormone, and thyrotropin-releasing hormone, all of which generally stimulate pituitary hormone release.
Right, the releasing ones.
Yeah. Then there's somatostatin, which inhibits the release of growth hormone and thyroid-stimulating hormone, and dopamine, which inhibits prolactin secretion. These hypothalamic hormones are then transported along nerve axons to a specialized region called the median eminence, a crucial interface.
And then how do these signals get from the hypothalamus to the pituitary? Is it just through regular blood circulation?
Not exactly. This is where a crucial anatomical feature comes into play. The hypothalamic adenohypophyseal portal veins. On stimulation, these neurons secrete their respective hypothalamic hormones directly into this unique vascular connection. This portal system acts as a direct, concentrated highway, carrying these signals straight to the anterior pituitary gland.
Okay.
This direct route is crucial because it prevents their dilution in the general systemic circulation, allowing for very precise and efficient delivery of the hypothalamic commands, ensuring a strong, targeted message.
So the anterior pituitary then reads these messages and produces its own hormones. What happens next?
Exactly. The hypothalamic hormones bind to specific membrane receptors on distinct subsets of anterior pituitary cells. This binding then regulates the secretion of corresponding pituitary hormones. These are often called trophic hormones because they feed or stimulate other endocrine glands. Examples include ACTH, TSH, GH, LH, FSH, and prolactin.
Okay.
These pituitary hormones then circulate throughout the body via the bloodstream to their respective target tissues. There, they activate their specific or cognate receptors, exerting cell-specific effects or critically stimulating the synthesis and secretion of the final target endocrine hormones like cortisol from the adrenal, thyroid hormone from the thyroid, or sex steroids from the gonads.
So it's a chain reaction, and each step seems to amplify the original signal. That's fascinating.
That's right. It's a clear example of feed-forward regulation. The initial signal from the hypothalamus is amplified by the anterior pituitary, which then elicits a regulated response from target tissues and stimulates the production of hormones by the endocrine targets. It's like a carefully designed cascade where a small initial signal from the brain leads to a significant directed response throughout the body.
But how does the body prevent an endless cascade of amplification? This is where the brilliant mechanism of negative feedback comes in, which ensures precise regulation and reestablishment of homeostasis. It's a fundamental principle of this entire system.
This is where the system acts like a thermostat. The endocrine target hormone, the final product, such as cortisol from the adrenal glands, thyroid hormone, or sex steroids, circulates back through the bloodstream. It then acts on both the hypothalamus and the pituitary gland. At these upstream sites, the target hormone binds to specific receptors and inhibits the production and secretion of both its hypothalamic releasing hormone and the regulatory pituitary hormone.
Okay, so the final hormone tells the bosses to cool it.
Pretty much. Think of it like a home thermostat.
Yeah.
When the hormone level gets too high, the system automatically turns down production until it's back in the comfortable range.
Yeah.
This self-regulating system is why our hormone levels are usually kept within a tight, healthy range, preventing both deficiencies and excesses.
And it's not just this direct feedback loop, right? Other parts of the body also feed into this broader regulatory network.
Correct. Other brain regions have inputs to the hypothalamic hormone-producing neurons, and hormones produced independently by other tissues can also target both the hypothalamus and anterior pituitary. This allows for diverse stimuli, from stress to nutrient intake, to integrate into hormone-level regulation, ensuring the body's response is holistic and highly responsive to internal and external changes.
So that's the complex anterior pituitary pathway. But the posterior pituitary, the other half of that gland, works differently, almost like a direct neural extension of the brain.
Exactly. In contrast to the anterior pituitary's complex portal system and multi-step feedback loops, the posterior pituitary, or neural hypophysis, operates on a much more direct line of communication. It essentially contains the endings of nerve axons that arise directly from specialized neurons in the hypothalamus, specifically the supraoptic and paraventricular nuclei.
Okay.
These hypothalamic neurons synthesize two key hormones, arginine vasopressin, also known as ADH, and oxytocin. These hormones are axonally transported down these nerves and stored in the posterior pituitary, from where they're secreted directly into the systemic circulation.
Bypassing the portal system entirely.
Completely. This bypasses the portal system and intermediate pituitary action, allowing for very rapid and direct effects on distant target tissues. This means a much faster, more on-demand delivery system for these particular hormones, perfect for acute needs like water balance or childbirth, where speed is paramount.
Now, to truly master this intricate system, let's walk through the key players in this axis, understanding who conducts whom and what the final performance looks like.
Let's break it down. First, from the hypothalamus, we have growth hormone releasing hormone, or GHRH. This acts on the pituitary to increase growth hormone, GH, which then stimulates target tissues, especially the liver, to produce insulin-like growth factor 1, IGF-1. IGF-1 is the primary mediator of GH's growth-promoting effects.
Then there's somatostatin, SST, also from the hypothalamus. Unlike GHRH, somatostatin acts on the pituitary to decrease both growth hormone, GH, and thyroid-stimulating hormone, TSH. So it acts as a crucial inhibitor, hitting the brakes on these two important pituitary hormones.
Precisely. And dopamine, DA, another hypothalamic output, acts on the pituitary to decrease prolactin secretion. It's unique because prolactin doesn't have a direct target hormone feedback loop in the same way as the others. Instead, its regulation is primarily under this tonic inhibitory control by dopamine.
For the body's stress response, we have corticotropin-releasing hormone, CRH, from the hypothalamus. This increases corticotropin, ACTH, from the pituitary, which then stimulates the adrenal glands to produce cortisol, our primary stress hormone.
And for thyroid function, thyrotropin-releasing hormone, TRH, from the hypothalamus increases both thyroid-stimulating hormone, TSH, and prolactin from the pituitary. TSH then acts on the thyroid gland to produce thyroid hormone, which is vital for metabolism.
Finally, in terms of reproduction, gonadotropin-releasing hormone, GnRH, from the hypothalamus increases both follicle-stimulating hormone, FSH, and luteinizing hormone, LH, from the pituitary. These, in turn, regulate the production of sex steroids. Estrogen in females, progesterone and more estrogen in females, and testosterone in males.
You see how each hypothalamic command sets off a very specific chain reaction, all designed for precise signaling to get the right hormone released at the right time, and then having feedback mechanisms to ensure a delicate balance. It truly is a remarkable internal orchestra.
The somatotropic family growth hormone and prolactin.
So those are the general classes of hormones and the master axis that controls them. Now let's zoom in even deeper on specific pituitary hormones. We're going to start with the somatotropic family, which includes growth hormone and prolactin, vital for everything from literal growth to milk production.
Yes. Pituitary hormones can be grouped based on their structural features. This helps us understand their common ancestries and signaling mechanisms at a more fundamental level. First, we have the pro-opiomelanocortin, or POMC-derived hormones. These include corticotropin, or ACTH, and alpha-melanocyte-stimulating hormone, MSH. What's important to grasp here is that these peptides are all generated from a single larger precursor protein, POMC, through a process called proteolytic processing, meaning the larger protein is precisely cut into smaller active pieces.
So one molecule gives rise to several different hormones.
Essentially, yes.
Right.
One parent molecule can yield multiple functional children peptides.
Then there's the somatotropic family of hormones, which is our current focus.
Correct. This group includes growth hormone, GH, and prolactin, PRL. In humans, this family also includes placental lactogen. Their defining feature is that the receptors for these hormones belong to the cytokine receptor superfamily. This indicates they share common evolutionary roots and often utilize very similar signal transduction pathways within the cell.
And the third group is the glycoprotein hormones.
Yes, this family is quite diverse and includes thyroid-stimulating hormone, TSH, also called thyrotropin luteinizing hormone, LH or lutropin, and follicle-stimulating hormone, FSH or phallotropin. In humans, the glycoprotein hormone family also includes placental human chorionic gonadotropin, or HCG. Their key structural characteristic is that they are glycosylated heterodimers. This means each hormone is made of two different protein chains or subunits linked together, and they have sugars attached.
Okay, two different parts.
The fascinating part is that they all share a common alpha subunit, but each one has a distinct beta subunit. It's this unique beta subunit that determines each hormone's biological specificity, which cells it will act on, and also influences its biological half-life in the bloodstream. It's like they all have the same engine block, but different specialized body designs that make them unique cars with different jobs.
Now let's hone in on the specific structures of growth hormone and prolactin. Growth hormone, or GH, is secreted by specialized cells called somatotropes as a heterogeneous mixture of peptides. This means your body naturally makes slight variations of the hormone. The principal form is a single polypeptide chain of 22 kilodaltons, or kDa.
Interestingly, an alternative splicing of the GH gene produces a smaller form, around 20 kK, which has equal biological activity and makes up a small percentage of circulating GH. This distinction is actually quite useful clinically. Recombinant human GH, the therapeutic version used in medicine, consists entirely of the 22 kilo form. This allows for detection of GH abuse by looking for the presence of the naturally occurring 20 kilonA form in someone's system. It's a clever way to spot illegal performance enhancement, proving that even subtle structural differences can have big implications for forensic analysis.
That's a fascinating nugget. What about how GH circulates in the bloodstream? Does it just float freely?
No, it doesn't. In the circulation, GH is largely bound to proteins. A specific protein derived from the GH-releasing hormone receptor binds a significant portion of the circulating GH. This binding is biologically significant because bound GH is cleared more slowly from the circulation. Its biological half-life is about 10 times that of unbound GH.
Wow, 10 times longer.
Exactly. This suggests that the bound hormone acts as a crucial reservoir, effectively dampening acute fluctuations in GH levels that occur due to its pulsatile secretion. It's like having a slow-release version built right into your blood, smoothing out the peaks and valleys and providing a more consistent signal to target tissues.
What about prolactin structure? Is it similar?
Human prolactin, or PRL, is synthesized by lactotropes. A portion of the secreted hormone is glycosylated. In the circulation, multimeric forms of PRL, where multiple PRL units stick together, can occur, as do smaller degradation products. However, similar to GH, the precise biological significance of these polymeric and degraded forms of prolactin is currently not known, remaining an active area of research.
And what about that third member of the somatotropic family you mentioned earlier, placental lactogen?
Ah, yes, human placental lactogen. It's structurally similar to both GH and PRL. It's synthesized in pregnant females, with maximal levels occurring near term. Its main role is to alter the mother's metabolism, primarily by reducing maternal insulin sensitivity. This metabolic shift is crucial as it favors nutrient availability and uptake for the developing fetus, ensuring it gets the energy it needs.
Given how vital GH is for growth and metabolism, it's no surprise its secretion is tightly regulated by a complex interplay of stimulating and inhibiting signals. It's a true hormonal orchestra with multiple conductors.
Indeed. Daily GH secretion varies throughout life. It's high in children, peaks dramatically during puberty, and then decreases with age and adulthood. It's also secreted in discrete but irregular pulses, and the amplitude of these secretory pulses is greatest at night, often during deep sleep. This pulsatile nature is a key characteristic of its release.
What are the main stimulators of GH release?
The primary stimulator is growth hormone-releasing hormone, or GHRH. This peptide, produced by hypothalamic neurons, stimulates GH secretion by binding to a specific receptor on the somatotropes in the anterior pituitary. This action triggers an increase in intracellular signaling molecules like cyclic AMP and calcium, which then directly stimulates both GH synthesis and its release. Interestingly, rare genetic mutations that cause loss of function in the GHRH receptor result in short stature in humans, highlighting the receptor's critical role in normal growth.
And there's another fascinating stimulator, ghrelin, often associated with hunger, right?
Yes. Ghrelin is a peptide that is also a potent stimulator of GH secretion through actions on a specific receptor, the GH secretagogue receptor. Ghrelin is synthesized predominantly in specialized endocrine cells located in the fundus of the stomach, but it's also produced in the pituitary and hypothalamus. Hypothalamic ghrelin is thought to directly stimulate pituitary somatotropes and also act on hypothalamic GHRH secreting neurons.
And it's linked to fasting.
Yes, both fasting and hypoglycemia increase circulating stomach-derived ghrelin levels, and this in turn stimulates appetite and increases food intake. Despite these mechanisms, the precise physiological role of stomach-derived ghrelin in GH secretion is still, well, a bit unclear. Animal models and conflicting clinical studies mean it remains an active area of research.
What other factors can modulate GH release?
A broad array of inputs can influence GH secretion. For instance, neurotransmitters like dopamine and serotonin and certain adrenergic receptor agonists all stimulate GH release. So do physiological states like hypoglycemia, strenuous exercise, stress, emotional excitement, the presence of sex steroids, and even the ingestion of protein-rich meals.
So, a broad array of inputs. What puts the brakes on GH?
In contrast, certain medications like beta-adrenergic receptor agonists, as well as naturally occurring substances like free fatty acids, glucose, IGF-1, and GH itself, all act to inhibit GH release. This brings us back to the crucial concept of negative feedback, which ensures precise control.
Growth hormone secretion is precisely regulated by these negative feedback loops, ensuring the body doesn't produce too much.
That's right. The negative feedback action of GH is mediated partly through GH itself, which, in turn, helps to stimulate the release of somatostatin, SST. SST is a powerful inhibitory peptide synthesized in widely distributed neurons throughout the body, including the hypothalamus.
And the other major player in this feedback is insulin-like growth factor 1, or IGF-1.
Correct. IGF-1 is a major peripheral effector of GH action. Its inhibitory effect on GH secretion is predominantly through direct effects on the anterior pituitary gland. But it also acts at the hypothalamus, where it stimulates SST secretion, which then inhibits GHRH and GH. So IGF-1 is hitting the brakes on GH production from multiple angles, ensuring tight control. Once synthesized and released, IGF-1 interacts with specific receptors on the cell surface that mediate its biological activities, triggering powerful growth and metabolic effects.
Let's delve a bit more into somatostatin, as it's a key inhibitory factor.
Somatostatin is synthesized as a larger precursor and then precisely cut into two active peptides, SST28 and SST14. SST exerts its inhibitory effects by binding to and activating a family of 5 related G-protein-coupled receptors known as SSTR1 through SSTR5. These receptors, when activated, essentially shut down certain cellular activities, like inhibiting cyclic AMP formation and opening potassium channels, effectively putting the brakes on hormone release. Host, speaker. Are all 5 SSTR subtypes equally important for GH regulation? Not quite. SSTR2 and SSTR5 are the most important for the regulation of GH secretion. They act by directly inhibiting somatotropes in the pituitary and also indirectly by affecting GHRH neurons in the hypothalamus. So somatostatin is essentially hitting the brakes on GH production from multiple angles, ensuring tight control.
Now let's talk about prolactin again, because this regulation is quite unique among the anterior pituitary hormones.
Indeed, it's unique in that hypothalamic regulation of its secretion is predominantly inhibitory. Unlike most other pituitary hormones that require a releasing hormone to be stimulated, prolactin is constantly under a tonic inhibitory brake.
So what's that main brake?
The major regulator of PRL secretion is dopamine, or DA. Dopamine interacts with a specific receptor called the D2 receptor, found on lactotropes, the PRL-producing cells, to inhibit PRL secretion. So a continuous brake is normally on prolactin production. While dopamine is the main brake, other hypothalamic peptides like thyrotropin-releasing hormone, TRH, and vasoactive intestinal peptide, VIP, do have PRL-releasing properties, but their physiological significance as major regulators in humans is currently uncertain.
Interestingly, some physiological factors that influence GH secretion also affect prolactin.
That's right. Many of the physiological factors that influence GH secretion also affect PRL secretion. Thus, sleep, stress, hypoglycemia, exercise, and sex steroids can all increase the secretion of both hormones, demonstrating a shared responsiveness to various bodily states.
But prolactin's most recognized role is in women, particularly during pregnancy and breastfeeding.
Absolutely. Prolactin acts predominantly in women, both during pregnancy and in the postpartum period while breastfeeding. During pregnancy, maternal serum PRL levels start to increase significantly, peaking at high levels near term. These levels then decline thereafter to pre-pregnancy levels unless the mother breastfeeds. When a baby suckles or the breast is stimulated, neural signals travel from the breast to the hypothalamus, causing a rapid and dramatic elevation of circulating PRL levels. They can rise tenfold within 30 minutes of stimulation.
And that's different from milk letdown.
Correct. It's important to note that this PRL response is distinct from milk letdown, which is mediated by oxytocin release from the posterior pituitary gland. Prolactin is about making the milk. Oxytocin is about releasing it.
Now let's go even deeper into the cellular level. How do these hormones actually tell a cell what to do? The answer lies in their specialized receptors and the intricate signaling pathways they activate.
Indeed, all effects of both growth hormone and prolactin result from their interactions with specific membrane receptors located on the surface of their target tissues. These receptors belong to the class 1 cytokine receptor family, indicating a shared evolutionary lineage and similar signaling mechanisms. This family includes receptors for other crucial signaling molecules like leptin and erythropoietin. These receptors typically have a part that binds the hormone on the outside of the cell and an intracellular part that mediates signal transduction, essentially relaying the message inside.
So let's break down how the growth hormone receptor, the GHR, gets activated.
The GHR is activated when a single GH molecule brings two receptor monomers together. GH first binds to one receptor and then links to a second, bringing them into close proximity. Now, here's a crucial point. Unlike some receptors, the activated GHR doesn't have its own built-in enzymatic activity. It can't directly phosphorylate other proteins.
Okay, so it needs help.
Exactly. Instead, GH binding induces a specific change in the receptor's shape that juxtaposes two molecules of JAK2, a cytoplasmic tyrosine kinase. This close proximity causes JAK2 molecules to activate each other.
So GAK2 is the real workhorse here, activating downstream signals.
Precisely. Once activated, JAK2 then phosphorylates key sites on the GHR itself and on various other proteins inside the cell that mediate downstream signaling events. These include major pathways involved in gene expression, like the STAT proteins, particularly STAT5, which targets the IGF-1 gene. Also pathways involved in cell growth and differentiation, like the RAS-MAPK pathway, and metabolic functions like glucose transport, involving IRS proteins and the PI3K pathway. It's a complex cascade of phosphorylation and activation, ultimately leading to the cell's response to GH.
So it's a complex cascade of phosphorylation and activation. But how does the body turn off this signal when it's done?
The body has clever ways to turn off the GH signal. As part of its action, GH induces the expression of specific suppressor proteins, called SOC proteins, and protein tyrosine phosphatases. These work through different mechanisms to disrupt the communication between the activated GHR and JAK2, effectively shutting down the signaling pathway and preventing overstimulation, ensuring fine-tuned control.
And the prolactin receptor, the PRLR, works similarly.
Yes, the effects of PRL on target cells also result from interactions with the cytokine family receptor that is widely distributed and signals through many of the same pathways as the GHR, such as the JAK-STAT pathway. The PRL receptor gene undergoes alternative splicing, which gives rise to multiple forms of the receptor that can subtly vary cellular responses. While human GH and placental lactogen can also bind to the ERL receptor and thus exhibit some milk-producing activity, PRL itself binds specifically to the PRL receptor and has no somatotropic GH-like activity. This highlights the distinct physiological roles of these hormones, despite their shared receptor family and common signaling pathways.
Now, let's explore the broader physiological roles of growth hormone and prolactin, beyond just their molecular mechanisms.
The most striking physiological effect of GH is its profound role in stimulating the longitudinal growth of bones. This is why it's so critical during childhood and adolescence. But its effects don't stop there. Even after the epiphyses or growth plates have closed in adulthood, GH continues to increase bone mineral density. It also significantly increases muscle mass and enhances kidney function. Furthermore, GH stimulates the differentiation of immature fat cells into mature ones, influencing fat metabolism.
And it has a significant impact on metabolism too, right? Almost counter to insulin.
Exactly. GH has potent anti-insulin actions in both the liver and peripheral tissues, such as fat cells and muscle. This means it can decrease glucose utilization by cells, effectively making more glucose available in the bloodstream, and it also increases lipolysis, which is the breakdown of fats for energy. However, it's crucial to understand that most of GH's anabolic or building up and growth-promoting effects are mediated indirectly through the induction of IGF-1.
Ah, right, the middleman again.
Pretty much. GH stimulates the liver and other tissues to produce IGF-1, and it's largely IGF-1 that carries out the actual growth-promoting work.
So IGF-1 is the primary messenger for growth. How does it travel in the blood?
Once synthesized and released, IGF-1 interacts with specific receptors on the cell surface that mediate its biological activities. In the bloodstream, circulating IGF-1 is largely associated with a family of IGF-binding proteins, or IGF-BP. These act as transport proteins, prolonging IGF-1's presence in circulation and helping to control its bioavailability.
There's compelling clinical evidence that underscores IGF-1's essential role, isn't there?
Yes. The essential role of IGF-1 in growth is unequivocally evidenced by patients with specific genetic mutations in the IGF-1 gene. These patients present with severe intrauterine and postnatal growth retardation. Fascinatingly, this severe growth defect is unresponsive to exogenous GH, but responsive to recombinant human IGF-1. This conclusively proves IGF-1's essential role as the direct mediator of many of GH's growth-promoting effects. This is a perfect example of a medical mystery solved by understanding the fundamental pathway.
And now, turning to prolactin, its primary roles seem much more focused.
Indeed. The effects of PRL are limited primarily to the mammary gland, where PRL plays a paramount role in inducing the growth and differentiation of the ductal and lobulo-alveolar epithelia and is absolutely essential for lactation or milk production. PRL induces the expression of specific genes important for mammary development, including those encoding milk proteins and structural components.
But earlier you mentioned PRL receptors are found in many other places in the body.
That's right. PRL receptors are present in many other sites, including the hypothalamus, liver, adrenal glands, testes, ovaries, prostate, and immune system. This widespread distribution strongly suggests that PRL may play multiple roles outside the breast. However, the precise physiological effects of PRL at these diverse sites currently remain poorly characterized, making this an exciting frontier for future research. It really makes you wonder what other secrets this milk-making hormone is keeping from us.
When things go wrong, pathophysiology of GH and prolactin disorders.
Now that we've explored the complex physiology of GH and prolactin, let's consider what happens when things go wrong specifically, when there's either too much or not enough of these crucial hormones.
When it comes to excess production, syndromes of excessive secretion of both GH and PRL are typically caused by somatotrope or lactotrope adenomas. These are benign tumors of the pituitary gland that oversecrete the respective hormones. It's an important clinical note that these adenomas often retain some features of their normal regulation.
So they still listen a little bit.
Exactly. This retention of regulatory sensitivity is key, as it often permits pharmacological modulation of their secretion, making drug therapy an important treatment modality.
So let's start with too much growth hormone. This leads to distinct clinical syndromes depending on the patient's age.
Precisely. If GH excess occurs before the epiphyses or growth plates in long bones have fused, that is, in children or adolescents, it results in increased longitudinal growth, leading to gigantism. You can imagine an individual growing to an abnormally tall stature. In adults, however, after the epiphyses have fused, GH excess causes acromegaly. Here, bones can no longer lengthen, so growth occurs in thickness and density.
What are the telltale signs of acromegaly, given its slow progression?
The symptoms and signs of acromegaly progress slowly, often leading to a delayed diagnosis. These include things like joint pain, carpal tunnel syndrome, generalized enlargement of internal organs, an enlarged tongue, hypertension, glucose intolerance, leading towards diabetes, headaches, lethargy, excessive sweating, and even sleep apnea.
Sounds quite debilitating.
It can be. The consequences are significant. Mortality is increased, predominantly due to an increased risk of death from cardiovascular disease. Fortunately, treatments that normalize GH and IGF-1 levels are crucial because they reverse this increased risk of mortality and ameliorate most of the other symptoms, highlighting the importance of timely diagnosis and effective management.
What about excess prolactin?
Hyperprolactinemia, or excess prolactin, is a relatively common endocrine abnormality. While most often caused by PRL-secreting pituitary adenomas, which are specifically called prolactinomas, it can also result from other conditions. These include hypothalamic or pituitary diseases that interfere with the inhibitory dopaminergic signals. For example, a tumor that simply compresses the pituitary stalk. Renal failure can also cause it, as kidneys normally help clear PRL. Primary hypothyroidism, due to increased TRH levels, is another cause. And even certain medications, like some antipsychotics, can lead to hyperprolactinemia by blocking dopamine receptors.
And what are the manifestations of hyperprolactinemia? How does it present?
In women, the manifestations of PRL excess include galactorrhea, which is inappropriate milk production unrelated to pregnancy or nursing, amenorrhea, the absence of menstrual periods, and infertility. In men, hyperprolactinemia causes loss of libido, erectile dysfunction, and infertility.
So what happens when there's not enough of these hormones?
Impaired production of GH and PRL also leads to distinct clinical syndromes with significant impacts on health and quality of life. Let's start with growth hormone deficiency, or GHD. In children, GHD presents with classic signs such as short stature, delayed bone age, meaning their bones look younger than their chronological age, and a low age-adjusted growth velocity. Their predicted adult height is also substantially below their mean parental height.
And in adults, the effects might be less obvious than short stature.
Right. GHD in adults is associated with decreased muscle mass and exercise capacity, decreased bone density, which increases fracture risk-impaired psychosocial function, and notably, increased mortality from cardiovascular causes. Overt GHD in adults usually results from pituitary lesions caused by tumors, or it can be secondary to trauma, surgery, or radiation therapy affecting the pituitary. Almost all patients who have multiple deficits in other pituitary hormones will also have deficient GH secretion, as the somatotropes, the GH-producing cells, are often among the most vulnerable to pituitary damage.
What about prolactin deficiency? Is that common?
Prolactin deficiency, or PRLD, may result from conditions that damage the pituitary gland, such as Sheehan syndrome, which is pituitary damage after severe postpartum hemorrhage. The sole consistent clinical manifestation of PRL deficiency is failure of postpartum lactation. Because of this very specific and limited clinical impact, PRL is not routinely given as part of general endocrine replacement therapy for pituitary insufficiency.
So we've covered the symptoms. How do clinicians actually confirm these diagnoses? It sounds like it can be a puzzle.
It can be. For the diagnosis of growth hormone excess, or acromegaly, while appropriate symptoms and signs should raise suspicion, diagnostic confirmation requires demonstrating increased circulating GH or IGF-1. The definitive diagnostic test for acromegaly is the oral glucose tolerance test, or OGTT.
Okay, how does that work?
In normal subjects, an oral glucose challenge suppresses their GH level to very low levels. This is because glucose tells the body it has enough energy, so growth-promoting GH isn't needed. However, patients with acromegaly either fail to suppress their GH level, or, paradoxically, they show an increase in GH level in response to glucose. This paradoxical response is a strong red flag that something is fundamentally off with GH regulation.
And for hyperprolactinemia, how do they pinpoint the cause? Is it always a tumor?
Not always. In patients with hyperprolactinemia, the major diagnostic question is whether conditions other than a PRL-producing adenoma are responsible for the elevated PRL level. Medications that inhibit dopamine signaling, primary hypothyroidism, or pituitary mass lesions can all elevate PRL. Of course, pregnancy is a physiological cause. Therefore, thyroid function tests and pregnancy tests are always indicated. Magnetic resonance imaging, or MRI, of the pituitary is also essential to look for a pituitary adenoma or any other structural defect that might elevate serum PRL.
What about diagnosing growth hormone deficiency, especially in adults?
The diagnosis of GHD should be considered in children with significantly short stature, accompanied by delayed bone age, a decreased growth velocity, and a predicted adult height substantially below their mean parental height. In adults, overt GHD is typically diagnosed when there's an underlying cause like a known pituitary lesion, and low GH production is demonstrated in response to standardized stimulation tests, or if the patient has multiple other pituitary hormone deficiencies, which strongly suggests significant pituitary damage.
Targeting hormones pharmacotherapy of GH and prolactin disorders.
Now that we've delved into the pathophysiology of GH and prolactin disorders, let's pivot to the pharmacological tools available for treatment. This is where modern medicine really leverages our deep understanding of these systems.
Absolutely. The initial treatment for gigantism and acromegaly is selective removal of the adenoma by transsphenoidal surgery. This minimally invasive surgery aims to remove the tumor while preserving healthy pituitary tissue. However, if surgery doesn't result in a cure, then radiation therapy or drugs that inhibit GH secretion or action are given. Pituitary irradiation may have significant long-term complications, leading to increased attention on pharmacological management, aiming for safer, more precise control. The overall goal of medical treatment is to normalize GH and IGF-1 levels for the patient's age and sex.
And this is where somatostatin analogues come in, which have really revolutionized medical treatment.
They have. These synthetic derivatives of somatostatin, like octreotide and lanreotide, have longer half-lives than native somatostatin and bind preferentially to specific receptors on GH-producing cells, primarily SSTR2 and SSTR5. By activating these, they effectively suppress GH secretion.
How is octreotide administered, and what are its properties?
Octreotide, when administered subcutaneously, is highly bioactive and has a serum half-life of about 90 minutes. For patient convenience, a long-acting, slow-release form, octreotide LAR, is administered intramuscularly once every 4 weeks, which is equally effective. In addition to its effect on GH secretion, octreotide can also decrease tumor size, although tumor growth generally resumes if treatment is stopped.
And lanreotide, is it similar?
Lanreotide autogel is another long-acting somatostatin analog. It also causes prolonged suppression of GH secretion when administered by deep subcutaneous injection every 4 weeks. Its efficacy appears comparable to that of long-acting octreotide.
And a newer one, paciriotide, has a unique receptor binding profile.
Yes, paciriotide is a long-acting somatostatin analog approved not only for acromegaly but also for Cushing disease. Paciriotide is distinct because it binds to multiple somatostatin receptors, but notably has its highest affinity for the SST5 receptor. In studies comparing it to octreotide, a greater percentage of patients treated with paciriotide reached treatment goals, suggesting potentially superior efficacy in some cases.
What are the common adverse effects for these somatostatin analogs? Are they easy to tolerate?
Gastrointestinal side effects, including diarrhea, nausea, and abdominal pain, are common, occurring in up to 50% of patients. These symptoms usually diminish over time and rarely require stopping therapy. Approximately 25% of patients may develop tiny gallstones due to decreased gallbladder contraction. Bradycardia, a slow heart rate, may occur in patients with underlying cardiac disease. Rarely they can lead to hyperthyroidism, so thyroid function should be checked periodically.
And there's a crucial distinction with pituitary regarding glucose metabolism, isn't there? That sounds important.
Yes, this is a very important point for you to know. All somatostatin analogues generally decrease insulin secretion. However, pituitary is different. It also decreases the secretion of certain incretin hormones, like GLP-1, which normally facilitate insulin release. As a result, glucose tolerance usually worsens significantly with pituitary and often requires diabetes medication. This is a key clinical consideration when choosing between these powerful drugs.
Beyond acromegaly, these somatostatin analogs have other fascinating therapeutic uses.
Indeed. Their ability to block the secretion of other hormones and growth factors gives them broad applications. They're used to treat symptoms associated with metastatic carcinoid tumors, such as flushing and diarrhea, and for specific tumors that secrete vasoactive intestinal peptide, causing severe watery diarrhea. They can also be used to treat patients with tumors that oversecrete TSH when surgery has failed. They even have diagnostic applications with modified forms used for imaging neuroendocrine tumors, showing their versatility.
That's incredible versatility. Now, if putting the brakes on GH production isn't enough, what if we just block the cell's ability to hear the GH signal altogether? This is where growth hormone receptor antagonists like pegvisomant come in.
Pegvisomant is approved for the treatment of acromegaly. It's a synthetic GH analog that functions as a GHR antagonist. It binds to the receptor and causes it to be internalized, but crucially, it cannot trigger the necessary change that stimulates downstream signaling or IGF-1 secretion. It occupies the receptor but doesn't activate it.
So it jams the lock.
Exactly. Think of it like a key that fits the lock but can't turn it.
How is it administered, and what are its common side effects?
The drug is administered subcutaneously with an initial loading dose followed by daily injections. The dose is then adjusted based on serum IGF-1 levels. It shouldn't be used in patients with unexplained liver enzyme elevation, and liver function tests should be monitored. Lipohypertrophy, or abnormal fat growth, can occur at injection sites.
There's also a significant monitoring concern with this drug, isn't there, regarding the tumor itself?
Yes, this is a crucial point for you to understand. Because pegvisomant blocks the action of GH and IGF-1, there's a concern that the resulting loss of negative feedback may actually increase the growth of GH-secreting adenomas. Because of this, careful follow-up by pituitary MRI is strongly recommended for patients on pegvisomant to monitor for any tumor growth.
Now let's shift our focus to treating excess prolactin or hyperprolactinemia. For this condition, the first line of defense is often a pharmacological one, leveraging the body's natural inhibitory signal for prolactin.
The therapeutic options for patients with prolactinomas include surgery, radiation, and treatment with dopamine receptor agonists. Because of the very high efficacy of dopamine receptor agonists in suppressing PRL production, they are generally regarded as the initial treatment of choice. Surgery and radiation are typically reserved for patients who either do not respond adequately or are intolerant of the drugs.
So, dopamine agonists are generally the first line. What do these drugs achieve?
Dopamine receptor agonists, such as bromocriptine and cabergoline, effectively reduce PRL levels, thereby relieving the inhibitory effect of hyperprolactinemia on ovulation and permitting most women with prolactinomas to become pregnant. Importantly, these agents generally decrease both PRL secretion and the size of the adenoma itself. Over time, especially with cabergoline, the tumor may decrease in size to the extent that the drug can potentially be discontinued without recurrence.
Let's look at bromocriptine, the benchmark in this class.
Bromocriptine is a semisynthetic ergot alkaloid. It primarily interacts with D2 dopamine receptors to inhibit PRL release. Orally, it's well absorbed, but only a small portion reaches systemic circulation due to extensive liver metabolism, so it usually requires multiple daily doses. A vaginal administration route is also available, which often results in fewer gastrointestinal side effects. Bromocriptine normalizes serum PRL levels in many patients and can decrease tumor size, though recurrence is common if stopped. At higher concentrations, it's also used in the management of Parkinson's disease and as an adjunct for type 2 diabetes.
And the side effects. I've heard it can be tough to tolerate initially.
Frequent side effects include nausea and vomiting, headache, and dizziness upon initial use. Less frequently, nasal congestion and CNS effects like psychosis or insomnia can be observed. These adverse effects can often be diminished by starting at a very low dose at bedtime with a snack and then slowly increasing the dose. Patients often develop tolerance to these adverse effects over time.
Cabergoline, though, seems to be the preferred choice now. Why is that?
Cabergoline is also an ergot derivative, but it has a significantly longer half-life, higher affinity, and greater selectivity for the dopamine D2 receptor compared to bromocriptine. Cabergoline is the preferred drug for the treatment of hyperprolactinemia because of its greater efficacy and lower incidence of adverse effects. It may even be effective in patients who do not respond to bromocriptine. It's typically administered once or twice a week.
What about the potential link between cabergoline and valvular heart disease? That's been a concern.
That's a crucial point, and it's important to clarify the nuance here. Cabergoline has been linked to valvular heart disease. However, this effect is seen primarily at the very high doses used in patients being treated for Parkinson's disease, and is generally not seen in the conventionally used doses for patients with prolactinomas. This is a crucial distinction that can cause confusion, but the context of the dose matters immensely here, as the doses for Parkinson's are typically far higher.
If you don't have enough of a crucial hormone, sometimes the most direct approach is replacement therapy. For GH deficiency, this has truly transformed lives.
Absolutely. Replacement therapy for growth hormone deficiency is well established in GH-deficient children and is gaining wider acceptance for GH-deficient adults. It's important to note that humans do not respond to GH from non-primate species. Historically, therapeutic GH was purified from human cadaver pituitaries, leading to limited availability and, tragically, a link to the transmission of Creutzfeldt-Jakob disease. However, currently, human GH, known as somatropin, is produced safely and abundantly by recombinant DNA technology, ensuring a consistent and safe supply.
How is somatropin administered, and what's its pharmacokinetic profile?
As a peptide hormone, GH is administered subcutaneously. Although its circulating half-life is only about 20 minutes, its biological half-life is considerably longer, and once daily administration is sufficient for therapeutic effect due to the presence of binding proteins we discussed earlier, which act as a circulating reservoir.
What are the main indications for GH treatment? Is it just for deficiency?
In children, GH deficiency is a well-accepted cause of short stature. With the advent of essentially unlimited supplies of recombinant GH, therapy has been extended to children with other conditions associated with short stature despite adequate GH production. This includes conditions like Turner syndrome, Noonan syndrome, Prader-Willi syndrome, chronic renal insufficiency, and children with idiopathic short stature. So this is not just about deficiency, but about using GH to optimize growth in various challenging conditions.
And in adults?
For adults, severely affected GH-deficient individuals may significantly benefit from GH replacement therapy. It's also FDA approved for AIDS-associated wasting and for malabsorption associated with short bowel syndrome based on GH stimulating the growth of GI epithelial cells.
Are there any important contraindications for GH therapy?
Yes, there are several important contraindications. GH is contraindicated for promoting growth in pediatric patients with closed growth plates, as longitudinal growth has already ceased. It should not be used in patients with acute critical illness, such as complications after major surgery or severe trauma. GH also should not be used in patients who have any evidence of active malignancy, as it can stimulate cell growth. In Prader-Willi syndrome, GH therapy requires careful supervision, as sudden death has been observed in severely obese or respiratory impaired children with this condition receiving GH.
What are the typical therapeutic uses and how is it monitored?
In GH-deficient children, somatropin is typically administered subcutaneously in the evening. Higher daily doses are employed for patients with conditions like Noonan or Turner syndrome, who often have partial GH resistance. Long-term response is primarily monitored by close evaluation of height, sometimes in conjunction with measurements of serum IGF-1 levels. GH is continued until the growth plates are fused and may be extended into the transition period from childhood to adulthood.
And for adults, what are the benefits and dosing considerations?
Benefits of GH treatment in GH-deficient adults include a decrease in fat mass and increases in muscle mass, exercise capacity, energy, bone mineral density, and quality of life. For adults, a typical starting dose is adjusted based on individual needs and response. An elevated serum IGF-1 level or persistent side effects mandates a decrease in dose. Conversely, the dose can be increased if serum IGF-1 has not reached the normal range.
There's also a crucial note about estrogen's impact on GH therapy, isn't there? Affecting the dose needed.
Yes, this is important. Because estrogen inhibits GH action, Women taking oral estrogen may require larger GH doses to achieve the target IGF-1 level. This is a significant factor in clinical management, as transdermal estrogen appears to have less of this effect.
What are the common adverse effects?
In children, GH therapy is associated with remarkably few side effects. Rarely, patients may develop intracranial hypertension with headache, nausea, or visual changes, so eye exams are recommended periodically. An increased incidence of type 2 diabetes mellitus has been reported, so fasting glucose levels should be followed periodically. Too rapid growth may rarely be associated with slipped growth plates or scoliosis. In adults, side effects associated with the initiation of GH therapy, such as peripheral edema, carpal tunnel syndrome, and joint muscle pain, occur most frequently in older or obese patients and generally respond to a decrease in dose.
What about drug interactions beyond estrogen, like with cortisol?
Recent studies suggest that GH therapy can increase the metabolic inactivation of cortisol in the liver. Thus, GH may precipitate adrenal insufficiency in patients with occult secondary adrenal insufficiency or in patients receiving replacement doses of glucocorticoids. This is attributed to GH's inhibition of a specific enzyme that converts inactive cortisone into active cortisol. Additionally, GH treatment may decrease insulin sensitivity. Therefore, the dose of insulin and or other hypoglycemic agents may need to be adjusted when GH therapy is initiated in diabetic patients.
Imagine taking your GH replacement not daily, but just once a week. That's the innovation somatostatin brings to the table.
Indeed, somatostatin, approved by the FDA in 2020, is a human GH analog engineered with a special albumin-binding moiety. This moiety extends the drug's half-life and reduces its clearance by allowing reversible binding to endogenous albumin. This modification makes possible once-weekly administration instead of the standard daily injection, significantly improving convenience for patients. Its enhanced pharmacokinetics make it the first human GH therapy that is administered to patients only once a week. It's approved for adults with GH deficiency, providing similar outcomes to native GH, and has a similar safety profile to daily GH.
If GH's main action is through IGF-1, then in some cases, providing IGF-1 directly makes perfect sense, particularly when the problem is with the receptor itself.
That's the rationale behind insulin-like growth factor 1, mecasermin therapy. Based on the hypothesis that GH predominantly acts via increases in IGF-1, recombinant human IGF-1, known as mecasermin, has been developed for therapeutic use. Its primary use is for patients with impaired growth secondary to specific issues, such as mutations in the GH receptor, patients who develop antibodies against GH that interfere with its action, or patients with IGF-1 gene defects that directly lead to primary IGF-1 deficiency.
How is mecasermin administered and how does it act in the body?
Mecasermin is administered by subcutaneous injection, and its absorption is virtually complete. Once in the circulation, IGF-1 is largely bound by specific proteins, which significantly prolong its half-life to about 6 hours. Both the liver and kidney metabolize IGF-1. While mecasermin does stimulate linear growth in patients with GH deficiency or idiopathic short stature, it is generally less effective than conventional therapy using recombinant GH.
Oh, interesting. So GH still does more on its own.
It seems so. This reinforces the idea that GH has effects beyond just IGF-1, even though IGF-1 is a major mediator.
And what are the key adverse effects and contraindications for mecasermin?
Side effects of mecasermin include hypoglycemia, or low blood sugar, which is important to manage by administering the drug shortly before or after a meal or snack. Localized fat overgrowth at injection sites can also occur. Other adverse effects are similar to those associated with GH therapy. Mecasermin should not be used for growth promotion in patients with closed growth plates and is contraindicated in patients with active or suspected cancer.
Finally, let's touch on two other hormones related to growth with very specific uses, tesamorelin and masamorelin.
Tesamorelin is a modified form of human GHRH designed to resist degradation and thus have a prolonged duration of action. Although it increases levels of GH and IGF-1, its primary clinical effect is to reduce visceral fat accumulation in a specific condition. Tesamorelin is FDA approved for the treatment of HIV-associated lipodystrophy, a condition of abnormal fat distribution in HIV patients, but not for general GH deficiency. This shows how these hormones can have targeted benefits beyond their main roles.
And masamorelin, that's a diagnostic tool.
Exactly. Masamorelin is a synthetic GH secretagogue receptor agonist, essentially mimicking the action of ghrelin, and is FDA approved only for the diagnosis of GH deficiency. It's administered orally, and specific serum GH levels after masamorelin administration confirm the presence of adult GH deficiency. This provides an orally available diagnostic tool, making testing more convenient than some other methods.
the gonadotropins regulating reproduction and more.
The next crucial set of pituitary hormones are the glycoproteins, often called gonadotropins, given their powerful effects on our reproductive systems. This family includes luteinizing hormone, follicle-stimulating hormone, and human chorionic gonadotropin.
LH, FSH, and HCG are indeed referred to as the gonadotropins because of their primary actions on the gonads, the ovaries in females and the testes in males. Together with thyroid-stimulating hormone, or TSH, they constitute the glycoprotein family of pituitary hormones. LH and FSH are synthesized and secreted by gonadotropins, specialized cells that make up about 10% of the hormone-secreting cells in the anterior pituitary. Human chorionic gonadotropin, HCG, is unique in that it is produced by the placenta only in primates and horses, highlighting its critical role in pregnancy. Their production is primarily stimulated by GnRH, which is further regulated by feedback effects of the gonadal hormones.
Now, let's explore the structure and function of these gonadotropins. You mentioned they are heterodimers with common and unique subunits.
To reiterate, each gonadotropic hormone is a glycosylated heterodimer, meaning it's composed of two different protein chains linked together, and they have sugars attached. Fascinatingly, they all contain a common alpha subunit, but each one has a distinct beta subunit that determines its biological specificity, which cells it will act on, and also influences its biological half-life in the bloodstream.
And the HCG beta subunit is particularly different.
Yes, among the gonadotropin beta subunits, that of HCG is the most divergent because it contains a carboxy terminal extension and extra carbohydrate residues that significantly prolong its half-life. This longer half-life of HCG has important clinical relevance for its use in assisted reproductive technology, making it a very practical tool.
Now let's look at the specific physiological roles these gonadotropins play in males and females.
In women, FSH, or follicle-stimulating hormone, primarily stimulates the growth of developing ovarian follicles. It also plays a critical role in inducing the expression of LH receptors on cells within the follicle and regulates the expression of an enzyme called aromatase, which is crucial for stimulating estradiol production. LH, or luteinizing hormone, acts on specific cells in the ovary to stimulate the de novo synthesis of androstenedione, a major precursor of ovarian estrogens. LH is also absolutely required for the dramatic event of rupture of the dominant follicle during ovulation, the release of the egg, and for the synthesis of progesterone by the corpus luteum, the remnant of the follicle after ovulation.
And in men, the actions of FSH and LH are generally less complex, but equally vital for reproduction.
In men, FSH acts on the Sertoli cells within the testes. These cells are crucial for supporting sperm development, and FSH stimulates the production of proteins and nutrients required for sperm maturation. LH acts on testicular Leydig cells. These cells are responsible for stimulating the de novo synthesis of androgens, primarily testosterone, from cholesterol. Testosterone is vital for male sexual characteristics and sperm production.
Given the precise roles of these hormones, their synthesis and secretion must be incredibly tightly regulated, with the hypothalamus acting as the master conductor through GnRH.
That's right. The predominant regulator of gonadotropin synthesis and secretion is the hypothalamic peptide GnRH. GnRH is produced by a small, specialized population of neurons located in the medial preoptic area of the hypothalamus.
And the pulsatile nature of GnRH secretion is incredibly important, isn't it? It can't be constant.
It's absolutely crucial. GnRH secretion is inherently pulsatile, varying dynamically in amplitude and frequency. This secretion is dynamically modulated by sex steroid feedback. While some evidence indicates that GnRH neurons themselves are inherently pulsatile, the developmental regulation of GnRH released through puberty and the modulation of GnRH secretion throughout the ovulatory cycle is largely governed by other neurons that co-express kisspeptin, neurokinin B, and dynorphin. Kisspeptin action ultimately governs GnRH secretion, providing a sophisticated layer of control.
It's fascinating how the body reawakens the system for puberty.
Indeed. At birth, the reproductive hypothalamic-Pituitary-Gonadal axis is active, but then becomes quiescent, remaining so until shortly before puberty. At that time, CNS inhibition decreases, and the amplitude and frequency of GnRH pulses increase. As puberty progresses, the GnRH pulses increase further until the normal adult pattern is established. The precise mediator gating this advancement to puberty isn't fully understood, but metabolic mediators related to body mass, adiposity, and energy balance may promote the reawakening of the axis and establish the rhythmicity of the ovulatory cycle in females and gonadal maturation in both sexes.
And this pulsatile release of GnRH is critical. What happens if it's continuous?
This is a key pharmacological principle. The intermittent release of GnRH is crucial for the proper synthesis and release of the gonadotropins. Conversely, The continuous administration of GnRH, for example, as a therapeutic drug, leads to desensitization and downregulation of GnRH receptors on pituitary gonadotropes, effectively shutting down gonadotropin secretion. This is a clever pharmacological trick, turning a stimulator into an inhibitor simply by changing its delivery pattern. It's also important to note that LH synthesis and secretion are acutely sensitive to GnRH pulses, whereas FSH is less so.
Now, how does GnRH actually work at the molecular and cellular level?
GnRH signals through a unique G protein-coupled receptor on gonadotropes. This receptor is distinctive because it lacks a typical part that normally helps turn off signaling, so it can activate robustly. Activation of the receptor leads to a signaling response characterized by robust activation of multiple pathways, including those that increase intracellular calcium and activate various protein kinases. These signals are rapidly quenched by specific feedback mechanisms, ensuring precise control.
So robust signaling, but tightly controlled. And the pituitary interprets the rhythm.
Exactly. This activation results in increased LH and FSH secretion and increased expression of glycoprotein hormone subunit genes. The magnitude of the cellular responses to GnRH stimulation is proportional to the amplitude and/or frequency of stimulation. Crucially, the gonadotrope is capable of interpreting GnRH pulse patterns, which is essential for the proper timing of the female ovulatory cycle. For example, rapid GnRH pulses generally favor elevated LH secretion and ovulation, whereas slow pulses favor FSH secretion and promote follicular development. The pituitary literally reads the rhythm of GnRH to know which gonadotropin to prioritize, an incredible level of biological sophistication.
How do sex steroids, estrogen, progesterone, testosterone regulate this GnRH gonadotropin axis? It's a complex dance of feedback.
Gonadal steroids regulate gonadotropin production at both the pituitary and hypothalamic levels, but their effects on the hypothalamus predominate. The feedback effects of gonadal steroids are dependent on sex, concentration, and time, showcasing an adaptive and dynamic regulatory system.
Let's look at females first. How does estrogen feedback work?
In females, as an ovarian follicle matures, it produces increasing amounts of estradiol. This estradiol then exerts negative feedback on both the hypothalamus and pituitary, promoting reduced pulsatile LH secretion. This primarily restrains the neural GnRH pulse generator through inhibition of kisspeptin neurons in the hypothalamus.
But there's also positive feedback that triggers ovulation, right? A switch flips.
Yes, and this is a critical exception to negative feedback. Sustained elevated estradiol levels near the end of the follicular phase exert positive feedback effects on a different population of kisspeptin neurons in the hypothalamus. This activates these neurons, resulting in a high stimulation of GnRH secretion, which in turn stimulates a dramatic surge in LH release. This LH surge is the direct trigger for ovulation. It's like a hormonal crescendo leading to the big event of egg release.
And in men, it's simpler.
Generally, yes. In men, testosterone inhibits gonadotropin production via actions in both the hypothalamus and pituitary. This occurs partly through direct actions of testosterone and partly via its conversion by the enzyme aromatase into estradiol, which then exerts its own inhibitory effects.
Beyond GnRH and sex steroids, other fascinating proteins play a role in fine-tuning gonadotropin secretion.
Indeed. Gonadotropin production is also regulated by inhibins and activin. Inhibins, specifically inhibin A and B, are made by cells in the ovary and testes. Crucially, they act directly in the pituitary to specifically inhibit FSH secretion without affecting LH secretion. So inhibin selectively reduces FSH.
And activin, on the other hand, sounds like it has the opposite effect.
Precisely. Independent of GnRH, activin is a positive regulator of FSH synthesis and secretion. It's produced in various tissues, including the gonads. While the physiological role of circulating activin is somewhat unclear, it primarily acts locally, for instance, by increasing FSH binding in the ovarian follicle in women, or by augmenting LH action in the testes in men, leading to increased androgen production and spermatogenesis. So while inhibin selectively reduces FSH, activin works to enhance it, providing another layer of intricate control.
How do LH and FSH actually work at the molecular and cellular level in their target tissues? Is it similar to GH?
The actions of LH and HCG are mediated by the LH receptor. Those of FSH are mediated by the FSH receptor. Both receptors are G protein-coupled receptors. They typically activate a pathway involving cyclic AMP, which then activates various downstream protein kinases to produce cellular effects. At higher hormone concentrations, these receptors can also activate other signaling pathways involving protein kinase C and calcium. In fact, most actions of the gonadotropins can actually be mimicked by direct application of cyclic AMP analogues, reinforcing the centrality of the KMP pathway in their mechanism of action.
Clinical implications disorders of the hypothalamic-pituitary-gonadal axis.
Now that we've charted the complex normal physiology of the hypothalamic-pituitary-gonadal axis, let's turn our attention to what happens when things go wrong, the clinical implications and disorders that arise from imbalances in this system.
When we talk about reproductive disorders related to hormones, one of the first distinctions clinicians make is where the problem lies in the axis, and that often comes down to gonadotropin levels. This leads to the crucial distinction between hypogonadotropic hypogonadism and hypergonadotropic hypogonadism.
Let's start with hypogonadotropic hypogonadism. What does that mean?
This refers to deficient sex steroid production, low testosterone in men, or low estrogen and progesterone in women that results from hypothalamic or pituitary defects. The defining characteristic is that circulating levels of gonadotropins, both LH and FSH, are either low or undetectable. The problem is upstream. The pituitary isn't sending the signals, or the hypothalamus isn't sending signals to the pituitary. The causes can be quite diverse. Some patients have GnRH receptor mutations, making the pituitary unable to hear GnRH. Other disorders can impair gonadotropin secretion, including pituitary tumors that compress or destroy gonadotrope cells, genetic disorders such as Kallmann syndrome, and even functional disorders such as exercise-induced amenorrhea, often due to an energy deficit impacting hypothalamic GnRH pulsatility.
So the problem is at the top, or in the pituitary, and the gonadotropins are low. What about hypergonadotropic hypogonadism?
In contrast, hypergonadotropic hypogonadism describes reproductive disorders caused by processes that directly impair gonadal function, meaning the ovaries or tests themselves are the problem. Because the gonads are failing to produce sex steroids, the normal negative feedback inhibition on the hypothalamus and pituitary is lost. This leads to a compensatory increase in the synthesis and secretion of gonadotropins, both LH and FSH.
So the pituitary is shouting, but the gonads aren't responding.
Precisely. The pituitary is shouting, but the gonads aren't responding.
What happens when puberty comes too early? That's precocious puberty.
Puberty normally is a sequential process requiring several years. It begins when GnRH neurons escape CNS inhibition and initiate pulsatile secretion of GnRH, which then stimulates gonadotropins and gonadal steroids, directing the development of secondary sexual characteristics. Normally, these initial signs do not occur before age 8 in girls or age 9 in boys. The initiation of sexual maturation before this time is termed precocious.
And precocious puberty can also be classified based on its origin, right? Central versus peripheral.
Yes. GnRH-dependent, or central precocious puberty, is caused by excessive gonadotropin secretion driven by GnRH. This condition may be due to benign brain tumors or other central nervous system abnormalities, but often no specific abnormality is found, in which case it's called idiopathic. A key diagnostic point is that in these cases, gonadotropin levels, LH and FSH, will be high, confirming the central origin. This must be differentiated from GnRH-independent precocious puberty.
So what causes GnRH-independent precocious puberty?
GnRH-independent precocious puberty results from the peripheral production of sex steroids in a manner not driven by pituitary gonadotropins. The problem is directly at the gonads or adrenal glands, not the brain or pituitary. Causes include adrenal or gonadal tumors that autonomously produce sex steroids, or activating mutations of the LH receptor in boys, which can constantly stimulate testosterone production. In these cases, gonadotropin levels will be low due to negative feedback from the peripherally produced sex steroids.
And how are these different forms of precocious puberty treated?
Synthetic GnRH analogues play important roles in both the diagnosis and treatment of GnRH-dependent precocious puberty. By continuously administering GnRH analogues, the pituitary's GnRH receptors are desensitized, effectively shutting down gonadotropin secretion and arresting puberty. In contrast, for GnRH-independent precocious puberty, drugs that interfere with the production of sex steroids, such as aromatase inhibitors, are used, with varying success.
The converse of precocious puberty is sexual infantilism, or delayed development.
Sexual infantilism refers to a failure to initiate the processes of pubertal development at the normal time. This can reflect either defects in the GnRH neurons or gonadotropes, leading to secondary hypogonadism or primary dysfunction in the gonads themselves. In either case, induction of sexual maturation using sex steroids is standard therapy. This generally suffices to direct sex differentiation. However, if fertility is the patient's goal, then simple sex steroid replacement is usually not enough. Therapy with either GnRH or gonadotropins is needed to stimulate appropriate germ cell maturation.
And this leads us directly to the challenge of infertility, where these hormones play a pivotal role.
Infertility, defined as a failure to conceive after 12 months of unprotected intercourse, is seen in a significant percentage of couples and is unfortunately increasing in frequency as people choose to delay childbearing. When the infertility is due to impaired synthesis or secretion of gonadotropins, that is, hypogonadotropic hypogonadism, various pharmacological approaches are highly effective and are often employed. In contrast, when infertility results from intrinsic processes directly affecting the gonads, for instance, severe ovarian or testicular damage pharmacotherapy is generally less effective, and other assisted reproductive technologies may be needed.
Pharmacological tools for gonadal disorders.
Now let's zoom in on the pharmacological tools themselves. This is where we see some incredibly clever strategies, like using GnRH, a hormone that stimulates a pathway in a way that actually inhibits it, all by changing the timing of its delivery.
That's right. A synthetic peptide comprising the native sequence of GnRH has been used both diagnostically and therapeutically. In addition, several GnRH analogues with structural modifications have been synthesized. These synthetic agonist congeners of GnRH have longer half-lives than native GnRH due to structural modifications, making them more potent and longer-lasting.
How do these GnRH agonist congeners work? It sounds paradoxical.
The key mechanism is this. After an initial transient stimulation of gonadotropin secretion, a brief flare, the continuous prolonged stimulation caused by these longer-acting analogs leads to a phenomenon called desensitization and downregulation of the GnRH receptors on pituitary gonadotropes. This effectively inhibits gonadotropin secretion, achieving what we call pharmacological castration. It's like constantly knocking on the door until the cell simply stops answering altogether.
What about their pharmacokinetics and formulations? How are they given?
The many formulations of GnRH agonists provide for diverse applications, from relatively short-term effects, like an assisted reproduction technology, to more prolonged action, like depot forms that inhibit gonadotropin secretion for precocious puberty or cancer treatment. They come as injections or implants, and even nasal sprays, though nasal forms have very low absorption compared to injected forms.
What are the main clinical uses for these GnRH agonists?
They are widely used to achieve pharmacological castration in disorders that respond to a reduction in gonadal steroids. A clear indication is in children with GnRH-dependent precocious puberty, where chronic administration of a depot form can arrest premature sexual maturation with minimal side effects. They are also used for palliative therapy of hormone-responsive tumors, such as prostate or breast cancer. These are generally used in conjunction with other agents to block steroid biosynthesis or action and avoid the initial hormone flare. GnRH agonists are also used to suppress other steroid-responsive conditions, such as endometriosis, uterine fibroids, and severe forms of acute intermittent porphyria. They've also been evaluated for their potential to preserve ovarian follicles in women undergoing cancer treatment. Additionally, long-lasting GnRH agonists have been used to avoid a premature LH surge and thus uncontrolled ovulation in various ovarian stimulation protocols for in vitro fertilization, allowing for precise control of egg maturation and retrieval.
What are the common adverse effects? Are they related to the pharmacological castration?
Exactly. The long-acting agonists are generally well tolerated, and side effects are those that would be predicted to occur when gonadal steroidogenesis is inhibited. These include hot flashes and decreased bone density in both sexes, vaginal dryness and atrophy in women, and erectile dysfunction in men. Because of these effects, therapy in non-life-threatening diseases such as endometriosis or uterine fibroids is generally limited to about 6 months to minimize adverse outcomes like bone loss. GnRH agonists are contraindicated in pregnant women due to their profound effects on reproductive hormones.
If agonists are about playing a trick with continuous stimulation, antagonists are much more straightforward. They simply block the receptor, preventing GnRH from acting at all.
That's precisely it. As antagonists, these drugs directly bind to and block the GnRH receptor on pituitary gonadotropes. This directly results in decreased gonadotropin secretion without the initial flare or transient increase in gonadotropin secretion and sex steroid biosynthesis seen with agonist analogs. This avoidance of the initial surge is a key clinical advantage in certain situations, particularly in assisted reproductive technology.
Let's talk about ganirelix and cetrorelix. They're used in IVF.
Ganirelix acetate and cetrorelix acetate are FDA approved to suppress the LH surge and thus prevent premature ovulation in ovarian stimulation protocols as part of assisted reproduction technology, RRT. This allows for very precise control over the timing of egg retrieval for IVF. Both are administered subcutaneously, and their effects are relatively rapid. Hypersensitivity reactions, including severe allergic reactions, have been noted, sometimes even with the initial dose. Like the agonists, GnRH antagonists are contraindicated in pregnant women.
And then there's degarelix, approved for prostate cancer. How is it different?
Degarelix acetate is FDA approved for the treatment of advanced prostate cancer. A key clinical advantage of degarelix is that it suppresses testosterone levels to achieve medical castration and lowers prostate-specific antigen, or PSA, more rapidly than GnRH agonists, crucially without an initial testosterone surge. This avoidance of the flare is a significant benefit for prostate cancer patients, especially those with symptomatic disease, as it avoids a temporary worsening of symptoms. Degarelix forms a depot gel at the injection site, allowing for slow, sustained release, resulting in a prolonged half-life and once-monthly administration. Common adverse effects include injection site reactions, hot flashes, and weight gain.
Now let's turn our attention to the natural and recombinant gonadotropins themselves. These are the hormones we actually give to help with reproductive challenges, and the way we obtain them has changed dramatically, improving their purity and effectiveness.
Gonadotropins are used for both diagnosis and therapy in reproductive endocrinology. Historically, the original gonadotropin preparations for clinical therapy were prepared from human urine. This included chorionic gonadotropin, obtained from the urine of pregnant women, and metotropins, which contain both FSH and LH activity, obtained from the urine of postmenopausal women. These early preparations had relatively low purity and were typically administered intramuscularly. However, highly purified preparations of human gonadotropins are now prepared using recombinant DNA technology. This offers significant advantages: less batch-to-batch variation, meaning a more consistent product, and higher purity, which allows for subcutaneous administration.
And this technology has even led to designer gonadotropins, right, with longer action.
Absolutely. This technology is also being used to produce modified forms of gonadotropins with increased half-lives or higher clinical efficacy. One such designer gonadotropin is FSH-CTP. It contains the beta subunit of FSH fused to a part of HCG that significantly increases the half-life of the recombinant protein. In clinical trials, FSH-CTP has been shown to stimulate follicle maturation in vivo when injected weekly, which is a huge convenience over daily injections.
Let's break down the different FSH preparations available.
Follicle-stimulating hormone has long been a mainstay of regimens for ovarian stimulation or in vitro fertilization. The original metotropins formulations contain roughly equal amounts of FSH and LH, along with other urinary proteins. Urofaltropin is a purer form of FSH, allowing for subcutaneous administration. And then we have recombinant FSH, like folitropin alpha and folitropin beta, prepared by expressing the genes for FSH in mammalian cell lines. These are purer and exhibit less batch variability than urine-derived preparations, allowing for subcutaneous administration. While they offer advantages in consistency, their superior efficacy or lower side effects compared to purified urine-derived gonadotropins have not been definitively established in large-scale studies.
What about human chorionic gonadotropin, or HCG? Is that still urine-derived?
The HCG used clinically originally came from the urine of pregnant women. However, recombinant HCG, or choriogonadotropin alpha, is now the predominant preparation used clinically, offering higher purity and consistency.
These hormones aren't just for treatment. They are incredibly powerful tools for diagnosing a range of conditions, from pregnancy to fertility issues.
Indeed. Let's start with pregnancy testing. During pregnancy, the placenta produces significant amounts of HCG, which can be detected in maternal urine. Over-the-counter pregnancy kits contain antibodies specific for the unique beta subunit of HCG and can detect pregnancy within a few days after a missed period. Beyond simple qualitative tests, quantitative measurements of plasma HCG can indicate whether a pregnancy is proceeding normally and can help to detect complications like an ectopic pregnancy or certain types of cancer.
And they can help pinpoint the exact time of ovulation for couples trying to conceive?
Precisely. Ovulation typically occurs about 36 hours after the onset of the LH surge. Therefore, urinary concentrations of LH, as measured with an over-the-counter ELISA kit, can be used to predict the time of ovulation. Urine LH levels are measured periodically to detect the rise in LH, which significantly facilitates the timing of sexual intercourse to optimize the chance of achieving pregnancy.
How are LH and FSH used to localize endocrine disease, to figure out where the problem is?
Measurements of plasma LH and FSH levels are highly useful in the diagnosis of several reproductive disorders, particularly in distinguishing the source of the problem. Low or undetectable levels of LH and FSH are indicative of hypogonadotropic hypogonadism and strongly suggest a hypothalamic or pituitary disease, meaning the problem is upstream. In contrast, high levels of gonadotropin suggest primary gonadal diseases, meaning the problem lies at the level of the ovaries or tests themselves. Furthermore, elevated FSH levels in women can indicate reduced fertility or are diagnostic of menopause in appropriate age ranges.
And for assessing male fertility or testicular function.
HCG can be used to stimulate testosterone production and thus to assess Leydig cell function in males suspected of having primary hypogonadism, for example, in cases of delayed puberty. A diminished response to HCG injections indicates Leydig cell failure, meaning the problem is directly with the testes' ability to produce testosterone. A normal response, on the other hand, suggests a hypothalamic-pituitary disorder, hypogonadotropic hypogonadism, and that the Leydig cells themselves are normal and healthy, but simply not receiving enough stimulation.
Finally, let's look at how we actually use these powerful hormones to treat specific conditions.
For male infertility, in men with impaired fertility secondary to gonadotropin deficiency, gonadotropins can successfully establish or restore fertility. Treatment typically is initiated with HCG to stimulate testosterone production. If sperm production does not occur or is insufficient with HCG alone, then recombinant FSH is added to fully induce spermatogenesis, as FSH is crucial for supporting the cells that nurse developing sperm. The most common side effect of gonadotropin therapy in males is gynecomastia, which is the enlargement of breast tissue, reflecting increased estrogen production.
And lastly, cryptorchidism, or undescended tests, can also be addressed with these hormones.
Cryptorchidism, the failure of one or both tests to descend into the scrotum, affects a significant percentage of male infants. Cryptorchid tests have defective sperm production and are at an increased risk for developing germ cell tumors. Hence, the current standard approach is to surgically reposition the testes into the scrotum as early as possible. However, because the local actions of androgens stimulate the natural descent of the testes, HCG has been used by some clinicians to induce testicular descent if the cryptorchidism is not secondary to an anatomical blockage. It's an attempt to medically nudge descent before surgical intervention is definitely required.
The posterior pituitary oxytocin and vasopressin.
Finally, let's explore the hormones of the posterior pituitary, focusing on oxytocin, often called the love hormone, but with far more profound physiological roles.
The neurohypophyseal hormones, oxytocin and arginine vasopressin, or AVP, are small cyclic peptides that are structurally very similar, differing by only 2 amino acids. While vasopressin plays an important role in water homeostasis, oxytocin plays crucial roles in labor and parturition and in milk letdown.
What about its synthesis and secretion? It's directly from the brain, right?
Essentially, yes. Oxytocin is synthesized as a larger precursor peptide in specialized neurons whose cell bodies reside primarily in the paraventricular nucleus and supraoptic nucleus in the hypothalamus. The precursor is rapidly cleaved to active oxytocin, packaged into secretory granules, and then secreted from nerve endings that terminate primarily in the posterior pituitary gland. This direct neural connection means rapid release into the bloodstream.
And it has broader projections and even other synthesis sites, not just the pituitary.
Yes. In addition to projections to the posterior pituitary, oxytocinergic neurons also project to various regions of the brain, including other parts of the hypothalamus, the olfactory nucleus, and regions involved in emotion and memory. Oxytocin is also synthesized in other sites beyond the brain, including the ovary and testes, though the exact physiological significance of this is not fully known.
How does oxytocin actually exert its effects at a cellular level?
Oxytocin acts via a specific G protein-coupled receptor called the oxytocin receptor, OXTR. In the human myometrium, which is the uterine muscle, oxytocin binding to OXTR on uterine myocytes triggers a signaling pathway that increases intracellular calcium. This then stimulates uterine muscle contraction. Oxytocin also increases uterine prostaglandin production, which further stimulates contraction. In human mammary tissue, oxytocin directly stimulates the contraction of myoepithelial cells through OXTRs to eject milk, a process known as the letdown reflex.
Now let's talk about the regulation of oxytocin secretion. This is unique because, unlike most hormones, it's augmented by positive feedback.
Exactly. Most of the hormones we've discussed are regulated by negative feedback. When levels rise, production slows. Oxytocin, however, is a fascinating exception, playing a key role in a vital process driven by positive feedback. Stimuli for oxytocin secretion include sensory input arising from cervical dilation, vaginal stretch, suckling at the breast, and even infant crying, which can trigger its release in mothers.
Is it easy to detect oxytocin in labor? given its importance.
Increases in circulating oxytocin in women in labor can actually be difficult to detect, partly because of the pulsatile nature of oxytocin secretion, and partly because of the activity of circulating oxytocinase, an enzyme that rapidly breaks down oxytocin. Nevertheless, increased oxytocin in maternal circulation is reliably detected in the second stage of labor, likely triggered by sustained distension of the cervix and vagina.
And this positive feedback is the key to its role in childbirth, right? It creates a cycle.
Yes, this is the core differentiator for oxytocin's regulation. Unlike the negative feedback regulation of most other pituitary hormones, oxytocin release is augmented by positive feedback regulation. This positive feedback is most evident during parturition, or childbirth. Oxytocin-induced uterine contractions activate mechanoreceptors in the cervix and uterus, which then signal back to the hypothalamus for more oxytocin release. This creates a self-reinforcing cycle that intensifies contractions, leading to labor progression. It's like a snowball effect. The more contractions, the more oxytocin, the stronger the contractions until the baby is delivered. For this reason, uterine hyperstimulation excessive or too frequent contractions is a crucial adverse effect of intravenous administration of oxytocin to augment labor that must be avoided by careful monitoring.
So let's go deeper into the specific sites where oxytocin acts, starting with the uterus.
In the uterus, during the third trimester of pregnancy, spontaneous uterine contractions progressively increase, leading towards labor. Oxytocin clearly regulates the frequency and force of these uterine contractions. Uterine responsiveness to oxytocin roughly parallels the increase in spontaneous activity and is highly dependent on estrogen, which significantly increases the expression of the oxytocin receptors, making the uterus much more sensitive to oxytocin. Exogenous oxytocin can enhance rhythmic contractions at any time. The uterus also becomes much more sensitive to oxytocin and increases its receptor number significantly in late pregnancy. Progesterone typically antagonizes the stimulatory effect of oxytocin, and the loss of sensitivity to progesterone that occurs in late pregnancy may contribute to the normal initiation of human labor, allowing oxytocin to exert its effects.
What about the breast, its role in milk ejection?
Oxytocin plays an undeniable and important physiological role in milk ejection, which is known as the letdown reflex. Stimulation of the breast through suckling or mechanical manipulation induces oxytocin secretion, causing the rapid contraction of the myoepithelium, which are muscle-like cells that surround the alveolar channels in the mammary gland. This action forces milk from the alveolar channels into large collecting sinuses, where it becomes available to the suckling infant.
And then there's the exciting research into oxytocin's role in the brain, sometimes called the social salience hypothesis. This goes way beyond childbirth.
Studies in rodents have strongly implicated oxytocin as an important CNS regulator of social behavior and affiliation, such as pair bonding and maternal behavior. The central role of oxytocin in human social behavior remains an active and exciting area of investigation. Research on its impact in humans has generated the social salience hypothesis, which attempts to reconcile the multiple, sometimes seemingly contradictory, effects of oxytocin on the CNS. In this framework, oxytocin is thought to modulate the response to social cues through interaction with dopamine neurons. It can enhance affiliative prosocial behaviors such as trust and bonding, attenuate stress responses, and regulate cooperation and conflict among humans in group social settings, influencing aspects like recognition, fear, or anxiety responses.
What brain regions are involved? Where does it act?
Brain regions extensively innervated by oxytocinergic neurons include the amygdala, which is involved in emotion and fear, the hypothalamus, important for homeostasis and stress, the hippocampus, critical for memory, and the midbrain, involved in reward and motivation. Oxytocin treatment has shown decreased activation of these key brain regions in response to stressful stimuli. The possible therapeutic benefit of drugs that manipulate CNS oxytocin on mental conditions with perturbations in oxytocin signaling, such as social phobia, addiction, and autism, is an exciting and rapidly evolving area of ongoing investigation. This is where our deep dive truly touches on the cutting edge of neuroscience and mental health.
Despite heightened interest in using oxytocin nasal spray to treat social disorders therapeutically, oxytocin has very specific and critical roles in obstetrics.
Its primary therapeutic uses are only to induce or augment labor and to treat or prevent postpartum hemorrhage. In 2007, oxytocin was even added to a list of drugs bearing a heightened risk of harm, despite its widespread use. This underscores the need for careful administration and monitoring. The U.S. FDA-approved label contains a specific notice. Elective induction of labor is defined as the initiation of labor in a pregnant individual who has no medical indications for induction. Since the available data are inadequate to evaluate the benefits to risks considerations, Pitocin, a brand of oxytocin, is not indicated for elective induction of labor. This highlights a significant medical and ethical debate regarding its use.
So when is labor induction with oxytocin indicated?
Induction of labor is indicated when the perceived risk of continued pregnancy to the mother or fetus exceeds the risks of pharmacological induction. For instance, if the mother has preeclampsia or the fetus is showing signs of distress. Oxytocin is the drug of choice for induction of labor for women with a suitably ripened cervix. It is administered by intravenous infusion of a diluted solution. It has a short half-life of 12 to 15 minutes and achieves a steady-state uterine response after about 30 minutes.
What are the potential side effects of using oxytocin for labor induction?
At high doses, oxytocin can activate vasopressin receptors and therefore have antidiuretic effects, causing water retention. Vasodilating actions of oxytocin have also been noted, which may provoke hypotension or low blood pressure and reflex tachycardia and increased heart rate to compensate.
It's also used to augment dysfunctional labor if things stall.
Yes. Oxytocin is also used when spontaneous labor is not progressing at an acceptable rate, for example, due to hypotonic contractions that are too weak or infrequent. As with labor induction, potential complications of uterine overstimulation are serious and include trauma to the mother or fetus due to forced passage through an incompletely dilated cervix, uterine rupture, which is a potentially life-threatening tear in the uterine wall, and compromised fetal oxygenation due to decreased uterine blood flow.
What about its critical role in preventing and treating postpartum hemorrhage after delivery?
This is a life-saving application. Oxytocin, typically 10 units intramuscularly, is given immediately after delivery to help maintain uterine contractions and tone. This is crucial for compressing blood vessels in the uterus and preventing excessive bleeding. Alternatively, it can be given as a continuous intravenous infusion until the uterus is well contracted, then the rate is reduced.
Finally, what about the opposite? Tocolytic therapy for established preterm labor, where the goal is to inhibit uterine contractions.
The inhibition of uterine contractions of preterm labor, or tocolysis, has long been a focus of therapy for women at risk of premature birth. Although tocolytic agents can delay delivery in approximately 80% of women, they generally neither prevent premature births nor significantly improve adverse fetal outcomes such as respiratory distress syndrome. This highlights the complexity of preterm birth and the limitations of current interventions. Specific tocolytic agents include beta-adrenergic receptor agonists, magnesium sulfate, calcium channel blockers, and the oxytocin receptor antagonist atosiban. Atosiban specifically blocks the oxytocin receptor, counteracting oxytocin's effects. It is widely used in Europe but is not FDA approved in the US. This is a direct counteraction to oxytocin's role, showcasing the pharmacological precision to manipulate these pathways. Outro.
Wow. We've just navigated a truly incredible landscape, from the fundamental definitions of hormones to the intricate dance of the hypothalamic-Pituitary-Endocrine axis, and then zeroed in on the specifics of growth hormone, prolactin, gonadotropins, and oxytocin, not just what they do, but how they're regulated, what happens when they go awry, and the powerful pharmacological tools we have to manage these imbalances. You've just gained a truly deep professional-level understanding of these vital systems.
By understanding these master orchestrators, the feed-forward and negative feedback loops, the nuances of receptor signaling, and the precision of pharmaceutical interventions, you now possess an incredible insight into how your body governs everything from growth and metabolism to reproduction, and even complex social behaviors. This kind of knowledge truly empowers you to understand your own health and the medical world around you with a new clarity.
Think about how this deep dive impacts your understanding of everyday life. Why your energy fluctuates, how stress affects your body, the miracle of fertility, or even the latest headlines about hormone therapies. This isn't just biology, it's the operating manual for your incredible self.
Given the profound influence of these tiny chemical messengers on our health, our development, and even our most complex behaviors, and considering the incredible precision of the body's feedback loops and the growing sophistication of our pharmacological tools, what new frontiers do you think will open up in understanding human potential or treating intractable diseases as we continue to unravel the subtle yet powerful language of hormones?
We hope this deep dive has sparked even more curiosity and given you a truly invaluable shortcut to being well informed. Thank you for joining us on this exploration.